we have lined up excellent speakers to cover various aspects of this session. I'll be taking up perfect biometry, can we do better? Then Dr. Santosh Bhide sir is going to talk on perfect surgery, consistent and reproducible results. Dr. Neeraj Manchanda is going to cover if we have PCR, can we achieve 20 by 20 in a case with PCR? Dr. Anand Parthasarathi is going to talk on phaco in post-keratorefractive surgery eyes. Dr. Jaspreet Sukhija from PGI is going to talk about optimizing results in pediatric cataract surgery. Dr. Nivian will cover up the topic of choosing the right IOL, monofocal, multifocal, trifocal or EDOF lenses. Dr. Parul Sharma will cover the part of astigmatism and optimizing toric IOL accuracy. Dr. Sachin Mahuli will cover cataract surgery in post-retinal surgery eyes, and Dr. Vanashri will talk on tackling refractive surprises post-cataract surgeries. So we start with the first talk of the day. This is how important is perfect biometry. We all know that in earlier times, cataracts was removed first and spectacle prescription was given last. But today we calculate the power of IOL first and cataract surgery is done afterwards. So IOL calculation plays a very important role to determine refractive outcome after the surgery. Since 75, just two parameters have been used, that is keratometry and axial length. But today we can customize the power of IOL to achieve near planar results even in highly myopic, hyperopic, or in extreme eyes like post-keratorefractive surgery eyes. Group of patients who greatly value their emmetropia, and when you tell them that they are required spectacles after the cataract surgery, they are extremely disappointed. And what are the major sources of prediction error for IOL power calculation? ELP prediction accounts for 35%, followed by axial length for 17%, keratometry 10%, and post-op refraction for 27%. And few subjects in the field of ophthalmology are as complex as IOL power formulas because it involves the use of mathematics, and we ophthalmologists are not very fond of mathematics in our field. And there are some hurdles in accurate estimation of effective lens position because older formulae, they worked on some assumptions. That is, the shorter eyes and flatter K eyes were supposed to have shorter anterior segment and shallow AC, accounting for shorter effective lens position, in contrast to longer eyes and steeper K eyes, which are supposed to have deeper anterior chamber and thus longer effective lens position. But Holliday taught us that there are 9 types of eyes. Eyes with normal anterior segment, 80% have short axial length and 90% have long axial length. And eyes with normal axial length, 2% may have short anterior chamber depth and 2% may have longer anterior chamber depth. So relationship between the anterior segment size and axial length is not proportionate in 80% of the short and 90% of the longer eyes. So older formulae are bound to fall in short and long eyes. Earlier formulas also had some more assumption. That is, they assumed a fixed ratio of anterior and posterior corneal curvature. Cornea was treated as a thin lens with 1.3375 refractive index. Actually, it is 1.37. Cornea was treated as sphere. It is a prolate. So it used to give us correct result in average eyes, but not in atypical and extreme eyes. So is it bad to just keep using the older formulas? Yes, because then with older formulas, only 1% of the surgeons achieved accuracy within 0.5 diopter in 92% of their cases. So this was a Rayner medal lecture given in 2016, and that they said it is possible by using newer formulas, we can achieve 91% of eyes within 0.5 diopter of the target refraction can be achieved. And so what are these newer formulas? I'll straight away jump to the newer ones: T2, Hoffer H5, Ladas, Olsen, Barrett True K, Barrett Universal, Hill RBF, Kane, EVO, and VRF. Prediction theory says if you more the number of variables to describe an event, more accurately outcome can be predicted. So as we move from 2 variables of axial length and keratometry to higher numbers, the accuracy improved. So we have 4 variables in Olsen, 5 variables in Barrett, and Holliday has 7 variables. Artificial intelligence is used in Hill RBF, and ray tracing is used in Oculix and phaco optics. And we also have some constants to give us idea about the effective lens position. SRKT had A constant, Hagees had A0, A1, A2, Hoffer Q and Holliday 2 have anterior chamber depth, Holliday 1 has surgeon factor, Olsen C constant, and Barrett has lens factor. But if these lens constants were arrived in earlier days when plano-convex lenses and contact ultrasound biometry was used. So we have to optimize our A constants, and you can optimize your A constant either with your own cases, or you also have various softwares like Dr. Holliday's IOL constant and Dr. Hagee's ULIV website. Surgeon who does not personalize his A constants, you'll find that on the left side, the accuracy within 0.5 diopter with the older constants was just 18%, and it jumps to about 70%, and within 1 diopter it jumps from 50% to 95%. Barrett Universal 2 is a newer formula which is recommended for all types of eyes, short to long eyes. Hill RBF uses artificial intelligence and pattern recognition, and it gives us better accuracy up to 91%. Olsen formula uses ray tracing. LADA Super formula is an intelligent formula because it combines the best performing portions of multiple third generation and fourth generation IOL formula. Kane formula uses, besides axial length and keratometry, also anterior chamber depth, lens thickness, CCT, corneal thickness, and gender of the patient to make its prediction. EVO 2.0 formula also uses these parameters, and it is also giving us good results in shorter eyes. Intraoperative aberrometry is not going to make lens calculations obsolete in the near futures, and its indication is in post-refractive surgery and astigmatic in toric IOL calculation. Ray tracing is used in Oculex and Olsen's, but there are limitations of ray tracing formulas, and it is not outperforming the standard formulas because they still depend on the accurate estimation of the effective lens position. So there is no reason to switch to ray tracing formulas. Hill RBF not only gives you IOL power, it also gives you accuracy level, whether it is inbound or out of the bound indication. So if we compare Barrett and Hill RBF, both are current, both are more sophisticated, although they use totally different premises, but they give us recommendations which are within 0.25 diopter of each other. So what should I use? Should I use multiple formulas and compare and average the results? Douglas Koch follows this policy. But Holliday, Barrett says use specific formulas for specific situation. So what is the best way to deal with shorter eyes? The best way is not Hoffer Q, which was traditional wisdom. It is better to use Barrett or Hill RBF. So, and in shorter eyes, these are the various studies which have been published, and they found that after Hill RBF and Barrett, even Kane formula is also giving us, Kane EVO are giving us good results. What is problem in longer eyes? That we get hyperopic surprise because the biometry tends to measure axial length longer than it actually is. So in longer eyes also, the older generation, third and fourth generation formulas are not giving good results, and we are slowly switching over to Barrett, Hill, RBF, EVO, and Kane formulas. And mind you, all these formulas are free of cost, available on the website. You can go there, feed your data, and get the results. So this is a meta-analysis which has been published, and you will find that within the first most accurate formulas, Kane, EVO, VRFG, Barrett Universal 2, Hill RBF, Pearl DGS are there, and you will find that Hoffer, Hagees, Holliday are not there in the most accurate first 5 formulas. This is another study which was published by Melis, and they also gave us similar results. So what are the steps you can do to maximize the likelihood of getting better outcomes? Please optimize your lens constants, validate your measurements, particularly if you are getting readings which are outside the normal range of axial length, corneal power, and the difference between the eyes. Please take measurements yourself in post-keratorefractive surgery eyes in shorter and longer axial lengths. Do not delegate this responsibility to your optoms because you are the most knowledgeable person of the team. Spend extra time counseling patients with short eyes or previous refractive surgeries, and please update yourself and switch to newer formulas. So we have reached accuracy of 90% within 0.5 diopter. The problem is not the formula any longer. Problem is the precision limit of the various variables which are used in the formula. And the precision limit for keratometry is 0.25 diopter. For axial length and anterior chamber depth, it is 0.1 millimeter. So these errors keep us at about 90% accuracy level. And there are also some ISO permitted tolerance. Imagine your calculation is 21.3 diopter. Nearest power available is 21.5. And ISO permitted tolerance for 21.5 is 0.4. So you wanted to implant 21.3, but the actual power implanted is 21.9. So you have given error of 0.6 even after you have done excellent calculation and excellent surgery. So has the stage come where we can use single formula for all eyes? No, we are still not reached that stage, but the formula which comes closest to it is Barrett Universal 2. So because this gives us accuracy in all short, long, and the medium size eyes. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years, and 90% accuracy is now achievable. So we should strive for what is achievable and not what is acceptable. Smartness is learning not only from your own but also from others' mistakes. So let us not only become experienced but also smart. And we are now on the verge of level of accuracy never before seen in ophthalmology. But for this, we have to use validated measurements, optimize your lens constants, and adapt to near technologies. Thank you, everyone, for your kind and patient hearing.